that's got us through to the official start time of this session. So looking around the room, that's what we've got all our speakers. So thanks everyone for being here. It's we've got 5 sessions in total today. Got off to a great start this morning, asking the question, well, what is men's health and why do we need to research it? And one of the reasons is because there's some bloody brilliant researchers in Australia who are doing some fantastic work, and we've got a handful of them here for this session to tell us about some of the work that they're doing. So coming up in the next hour or so, we have this session, which is on. I'm going to just flick to my program to remind myself exactly what we called this session. And this session we've called Big Ideas, Sharing Research That Makes a Difference. Because what's the point of researching something if you don't actually translate that into some specific action? So we've got 4 speakers in this session. We have Professor Jane Pirkis, who amongst many other things has recently won a heap of money through the Million Minds Mental Health Research mission, and I hope she's going to be telling us about that. But Jane could fill a whole day telling us about the research that she's done, so I'll leave it for her to decide how she fills her 10 minutes. Dr. Zak Seidler, who's most people will first come across with his work, the Man Island Project, who is now the director of professional training at Movember. And again, Zach is doing all sorts of wonderful work and could fill an entire day himself. We have Dr. Galina Daragonova, I hope I got that right, who is at the Australian Institute of Family Studies, which manages the 10 to Men longitudinal study, which came out of the first male health policy in just after 2010. So there's ongoing longitudinal research into men in Australia, and Dr. Daragonova will be giving us an update on that, no doubt. And we have Dr. Eleanor Quested, who, amongst many other things, is leading research on Aussie Fans in training, which is a program using sport as a way of engaging men, with a particular focus on that one of reducing overweight and obesity amongst male AFL fans. So a real nice mix of researchers. I'm just going to hand over to them one by one to take about 10 or 12 minutes to share whatever they want to share about their research, what they're up to, how it's been translated into action and making a difference for blokes, or how it might be translated into action in future. And then we'll open up to questions and discussion when they've all had a good go at introducing themselves and their work. And if you don't mind, Jane, I'm going to come to you first. You are currently the most popular person in men's health research, because no doubt everyone thinks you've got $5.6 million in your back pocket and everyone wants a bit of it, but I'm sure that's not how it works. But congratulations on your huge success in winning that funding grant, and I look forward to what you've got to update us on.
Thanks, Glenn. That's great. I'm trying to share my screen, but it's telling me that the host has disabled it.
Then I will address that within a matter of seconds. Okay, so I'm making you a co-host now, Jane.
Okay.
And then you will be able to share screen.
Oh, yes, okay.
Brilliant.
So you can see that, yeah. So does that look all right for everybody? People can see it?
Perfect.
Okay, good, thanks. So thank you, Glenn. And yes, we were very fortunate to receive funding through the recent Million Minds mission round of funding, which was a call for research into suicide prevention. So I got together a fantastic group of other researchers and partners working in the field to put together a bid that we thought was really strong, that was specifically about preventing suicide in boys and men. And there are a number of people on the call today who are involved. So as you predicted, Glenn, I'm actually going to talk about that today and just give a bit of a flavour of what it is that we're hoping to do. So if you've worked in suicide prevention for as long as I have, which is a long time, you can't help but be concerned about male suicide. And that's because more than 3/4 of all suicides in Australia, and in fact in most Western countries, are by males, which in Australia means that more than 2,300 fathers, sons, husbands and brothers are lost to us each year. So that's a pretty sort of stark statistic, I think. And that's why we've been working quite hard to try to make sure that there's an emphasis on male suicide prevention in the more general suicide prevention field. Another way of looking at those statistics is that if you took the 100,000 capacity MCG on the days when we were, back in the day when we were allowed to go to big events, if the MCG was full of men and boys watching the Boxing Day test, and I'm not a sporting person, but I do realise that what I'm showing you here isn't cricket, then during that following year, we would lose 18 or 19 of those men and boys to suicide, which again is a pretty stark way, I think, of thinking about it. So as I said, we got together this fantastic team. This is the front cover of our application, which we submitted in January this year. So other people, some of whom, as I said, are on the call, who are involved, were George Patton, John Olive, who I know is here, Nicola Reevely, who works with me, Kathy Mihalopoulos, who's from Deakin, Tony LaMontagne, who's from Deakin as well, Simon Rice, I'm not sure whether Simon's here, but I'm sure he will be later if he's not, Zach, who I can even see on my little screen still and is about to speak shortly, Kylie King from Monash, and Stuart Vella from the University of Wollongong. And then we also had a number of associate investigators. I won't go through all of their names, but some of those people are involved with organisations that are delivering really great things in male suicide prevention. So the kind of rationale behind what we're trying to do in this project is take that absolutely indisputable fact that males dominate suicide statistics and think through why that might be and how we might address it. So people have talked about this over time and put forward various reasons for why men and boys might dominate suicide statistics. So reasons like the following get put forward. So they're more likely to choose lethal means, they're more likely to use drugs and alcohol in a chronic way, but also in an acute way immediately before a suicide attempt. They're more likely to withdraw in the face of stress, and they're less likely to seek help. So those statistically, those things are fairly indisputable as well, but they seem to us like fairly blunt kind of explanations. And we wondered whether there were kind of reasons behind the reasons that might be contributing. So we started to think, and particularly Zach and John and others have helped me think this through, about whether there's something about masculinity, that socially constructed gender ideal for boys and men that is absolutely socially constructed, that might be leading to some of these things. So for example, in Australia, there is a bit of a culture that that if you're a bloke, drinking with your mates is a desirable thing to do. So that sort of thing might explain some of the drugs and alcohol stuff. So we started thinking about this this notion of masculinity that might underpin some of the things that lead to this situation we're in where males dominate suicide statistics. And we started thinking a bit more about how that might play out, particularly with things like help seeking. So I'm preaching to the converted absolutely in this room when I say there are multiple masculinities. There's no single masculinity. But I think it is fair to say that the dominant one, at least in Australia, promotes norms like self-reliance, stoicism, being independent, avoiding negative emotions. And it's absolutely true that these qualities are great in lots of circumstances, and we're certainly not saying in this work that you want to quash those sorts of characteristics, but I think it probably is true to also say that they can run counter to boys and men seeking help if they're not travelling so well. But importantly, that's not the end of the story. So it's not just that those masculine norms might inhibit help seeking, but there's also the issue that if boys and men do seek help, often they find themselves approaching services that aren't ideally suited to them and may not meet their needs. So we wanted to address the issue from both ends. So in suicide prevention, and again, I'm probably preaching to the converted, to at least half the people on the call, and forgive me if I'm telling you things you already know, but in suicide prevention, people often distinguish between different types of interventions. So preventive interventions. So they talk about universal interventions that target the whole population without distinguishing who in the population might be at risk. Then you move on to selective interventions that target people who aren't actively suicidal yet, but have risk factors that might heighten their risk of suicide further down the track. And then indicated interventions are really at that pointy end, which are targeting people who are actively experiencing suicidal thoughts or behaviours. So we sort of overlaid our thinking with this kind of framework for thinking about the different kinds of interventions that there might be. And so just remembering what I said about men and boys not being so inclined to seek help, but also if they do seek help, not necessarily ending up at services that are geared very well towards them, we thought it would be good to test some interventions at that universal selective end that are designed to increase help seeking, that are delivered to men and boys in various settings where they live, work and play, usually through workshops or some kind of training, or perhaps media mediated kind of interventions. But at the same time, we thought it was important to make sure that we didn't forget the other end. So we wanted to also look at some interventions that are designed to ensure that when boys and men do seek help, it's absolutely fairly and squarely appropriate to their needs. So there are some of those interventions, they do exist. And in fact, most of the interventions we're testing already exist, and I'll talk about them in a minute. But so far, they haven't been perfectly evaluated. So there have been some evaluation efforts, but they're a bit piecemeal and haven't allowed us to get to the point where we can really say, well, the evidence is absolutely in for that particular intervention. So our aim was to really try to see whether we could ramp up the strength of the evaluations of some of these things. So just to summarise, and Glenn, I can't actually see you. I can't see whether you're looking like I'm going on for way too long or not. So for us, the problem is, I don't know if you can see my cursor, but there are males at risk of suicide out there. The majority of them don't seek help. And if they don't, that often leads to negative outcomes. A minority do seek help, but then of those, only a minority receive help that's appropriate, services that's appropriate to their needs. So the majority don't, and they also are likely to have negative outcomes, either because their needs aren't met, or they just have an adverse experience, an aversive experience with the services. So the proportion of all these men over here who end up having a positive outcome is very small. So the solution for us is to look at whether there are some universal and selective interventions that encourage help seeking through a focus on masculinity that might help at this top end, upstream end, and whether there are some indicated interventions that are more tailored to the needs of boys and men that might improve the situation at the what I was calling before the pointier end. So our partners, I mentioned we had some great partners in this enterprise. We've got, I think there are 14 here. So we've got Tomorrow Man, we've got Gotcha for Life, Movember Foundation, Mates in Construction, Mental Health First Aid, Victorian Men's Shed Association, Heiress Films, Every Mind, Lifeline, Mental Health, Suicide Prevention Australia, the Australian Psychological Society, the fabulous Australian Men's Health Forum, and Stop Male Suicide. So all of those partners got together with us and were really absolutely behind putting this proposal in. Some of the partners are also responsible for funding or delivering the interventions that we're testing. So I'm fairly sure I probably am starting to run out of time, so I won't go into great detail other than to say that we have 5 universal or selective interventions, which are Breaking the Man Code, Ahead of the Game, Mates in Construction, Mental Health First Aid for the Suicidal Person, which we're modifying for use in men's sheds, and then a yet to be developed media-based male suicide prevention campaign, which will take the form of some kind of media campaign. We're not quite sure yet. So we've got those 5 universal, selective or indicated interventions, universal or selective interventions, and then we've got 2 indicated interventions that we're testing, both of which we're kind of morphing a bit. So we're going to work with Lifeline to create some specialist services that are specifically targeted towards male callers to Lifeline. So the format is yet to be finalised. We'll do lots of consulting about what male callers to Lifeline want, but examples might be they might have a choice of the gender of the telephone crisis support worker they speak to. We might work with them to consider whether particular modalities are more attractive to men and boys than others. And then the second indicated intervention, which I particularly won't talk about too much because I know Zach will talk about it in a minute, is Zac's intervention, Man Island, which he tells me has, can I say this, Zac, is having a little rebranding at the moment. So I'll let him talk to you about that. But the idea is that we'd use Zac's Man Island intervention to train mental health psychologists so that they were able to provide psychological services to men and boys that were absolutely fairly and squarely tailored to their needs. So the way we're doing this, the research itself employs randomized controlled trials. So testing the interventions in a way that's as rigorous and as controlled as possible, and there'll be appropriate comparison groups each time. So in each case, we're looking at whether the interventions that we're looking at are effective, and importantly, also whether they're cost effective. So we've sort of notionally thought about the work in terms of these 3 work streams. So the first work stream is about the universal and selective interventions. The second one's about the indicated interventions. And then we bring it all together in work stream 3 by doing some economic modelling to work out what would happen if you scaled these interventions up. So I won't go into more detail than that, but that's just maybe a flavour of what we're trying to do. So we've got our fingers crossed. I thought the title for this session, Glenn, was a great session, a great title. I liked the thought of sharing research that makes a difference, and we've absolutely got our fingers crossed that this will make a real difference, help us to make a quantum leap in terms of what we know about what really works in male suicide prevention. So Scott Morrison, Glenn will recognise this photo because he took it. Scott Morrison was at a suicide prevention forum last year. He's shown a particular interest in suicide prevention and has set a target of towards 0 for suicides in Australia. And we wrote this in the application, and I firmly believe this, that preventing suicide among boys and men would go further than any other single approach to achieving that goal of working towards 0 suicides. So I'll stop there. I'll stop sharing my screen. I'll take Scott Morrison off the screen. But I'm happy to answer any questions or take your guidance, Glenn, as to how you want to organise things.
Sure. So I'll let you go on a little.
Sorry.
I'll let you go on a little bit there, Jane, I was going to say, because I wanted to make sure that we got the full presentation. In fairness to the presenters, I'll move on. But what we'll do is, please, if you've got questions, start to drop them now in the chat box, and Jane, keep an eye on that.
I will.
any you can pick up in the chat box, fantastic. And we'll come back for questions at the end where if we haven't had the opportunity to respond or we want to pick up a particular question from there. So what a fantastic start. There's Jane's opening bid for research that makes a difference coming in at 5.6 million. Be good to see how that all, what's the timescale, Jane? When do you expect to see the
so we've got 4 years, and the idea is that the trials will be a bit staggered over that 4 years.
Yeah. Okay, so brilliant. So 4 years seems like a long time, but you'll know, because I believe you were very much involved in 10 to Men at the outset. Longitudinal research goes on a lot longer than 4 years, and we're going now to Dr. Galina Daraganova of the 10 to Men study at the Australian Institute of Family Studies to give us an update of what's happening with that ongoing and important piece of research, and how it's been, and to find out how it's been applied or could be applied. So Galina, are you there?
Yes. Hello, everyone. Glenn, I'm really sorry. I will correct you slightly. Galina.
Galina.
The surname is perfectly fine. I would also like to apologize. I won't be able to share the screen and have my video on. So I will share the screen. I'll see. Hopefully it will work. Can you see the presentation, Glenn?
No, we've just got your name.
So maybe you need to also give me the.
You know, you've got permission.
Okay.
If you turn.
Oh, good.
There you go. Here we go. That's it.
Perfect. Hello, everyone. Before I start, I would like to acknowledge the traditional owners of the land we meet today and pay my respect to the elders past and present. I would also like to acknowledge the 10 to Men participants for contributing to this great initiative, the Department of Health for funding this initiative, the University of Melbourne, in particular Jane Pirkis and Roy Morgan Research for designing and conducting the first 2 waves of the study, Social Research Center and 10 to Men team at ACE. Without all these people, I wouldn't be able to present today. So I'm very briefly introduce the 10 to Men study, talk about the design, cohort characteristics, and give you a sneak peek into some of the longitudinal results. The results are not officially public yet, so would appreciate if they are not discussed outside of this session. Just very briefly, I'm sure that I don't need to convince anyone who is attending this session today that male health is a significant issue, which has only recently begun to receive the attention that it warrants. And the health profile of males in Australia mirrors that in other Western countries. Australian males have worse health outcomes. They have got shorter life expectancy than female counterparts. They are more likely than females to experience some of the health problems that account for the greatest disease burden in Australian society. They have higher rates of behaviors. They've got higher rates of behaviors that place them at risk for particular health problems. And they are less likely, as Jen already mentioned, to visit health professionals. So all of this has been discussed and addressed in a special discussion by the government in 2010 when they released the National Male Health Policy. As part of this government commitment was to improve the health of Australian males and make the health system a little more responsive to their distinctive needs. With the key priorities to build a strong evidence base on male health and well-being, inform policy programs and initiatives. There are a number of initiatives that came out of this male health policy, but one of them was the commissioning of the 10 to Men study. The 10 to Men study is a longitudinal study that had its vision to improve male health outcomes at different life stages by providing the evidence about the health and well-being of males. A little bit about the theoretical framework that was implemented by the University of Melbourne, who won the tender and designed the whole study from the very beginning. So the study was based on a theoretical framework that brings together risk and protective factors and health status in order to allow tracking the different pathways of men of diverse socioeconomic backgrounds through the life course. And I think it's very important to emphasize that one of the biggest goals of this study was to ensure that it's not just sits within the health portfolio, and social determinants play a huge role in the health outcomes of males. Just very, very briefly, life course of Tantamount study to date. As I mentioned, in 2010, it was male health policy was released. In 2011, Melbourne University were awarded a tender and designed the Tantamount study. 2 data collections were undertaken by the University of Melbourne, the first one in 2013-14, the second one in 2015-16. 2017-18, the study transferred to the Australian Institute of Family Study, and we are currently going into the field at the end of July for the Wave 3 data collection. The data collection has been postponed for Wave 3 due to the COVID context. The study actually governed by the Institute of Family Studies, but in collaboration with the Scientific Advisory Group and the Community Reference Group. Scientific Advisory Group has a lot of world-leading researchers, national researchers, and they provide advice on the content design and also data linkages and methodology. The study is also supported by the Community Reference Group, who ensures participants' engagement and community engagement with the study. A little bit more about the Tantamount Sample. It's a nationally representative study, and the participants were recruited via multi-stage sampling. I'm not going to go into more details about that, but happy to answer any questions. At Wave 1, 3 different cohorts were recruited. Boys age 10 to 14, young men, age 15 to 17, and adults age 18 to 55. The cohort of boys and young men were relatively representative of the Australian boys and men based on the ABS census. When we talk about the adults cohort was slightly less representative. Males were slightly older. However, there was a very good representation of different conditions, health conditions and socio-demographic backgrounds that would allow Tantamount to understand the health trajectories of males. The other thing I wanted to say that at Wave 2, about 75% responded at Wave 2. The biggest attrition was observed among young men. About 28%, we lost about 28% at Wave 2, and the greatest attrition was among boys. The response rate about 78%. It was a lot of questions. The Tantamount contains about 30 domains, which can be grouped into key areas: behaviors, health status, social determinants, use of health services, well-being, health knowledge. And actually, it was more than 800 variables that were derived from these 30 domains. At Wave 3, the content has been slightly extended and updated. Questions about gambling, use of e-cigarettes, and more questions about the drug use, gender, identity, relationship quality, individual income, and health checkups. Also, questions about COVID were added and their experiences during COVID. This is very, very briefly and very, very quickly about the background of the study. And I think now I would really like to focus on picture of male health based on the Wave 1 and 2 data. Some initial findings based on Wave 1 mainly, as I mentioned. Study participants were asked about their current health, and you can see that the prevalence of some health issues affected each of the sub cohorts. For example, looking at depression, you can see that the 6th most common health issue amongst boys, depression is the 6th most common health issue amongst boys, 3rd in young men, and while currently being the #1 health issue among adult males. And just to remind you that the data was collected in 2013-14, the prevalence of some individual conditions increases with age, as for example, we can see with depression. And with more waves of data, we will be able to examine the incidence of particular conditions and also the risk and protective factors associated with their onset. A couple of things I wanted to mention here. So for example, focusing specifically on mental health, it has been found that the burden of mental ill health remain really high among Australian men with up to 25% experiencing a diagnosed mental disorder in their lifetime. and 15% experiencing disorder in the 12-month period. Depression and anxiety were the most common mental health issues experienced by Australian male. And if you look at the two graphs that on this slide, so the first graph shows you the prevalence by age groups, and we can see that there is a steady increase with age in the depression conditions, while anxiety remains pretty stable. And the other thing, what is actually very, very important to mention and highlights what already been mentioned by Jen, that out of those people who are experiencing symptoms of depression, while 80% are visiting GP, more than 60% are actually not getting any specialized services. And the other thing that if we look at the longitudinal changes, the change in the depressive symptoms is really, really small. So among almost 80% not experiencing any changes. And if you can see, if you look at the clinically meaningful worsening, it's basically showing that the group that is at most risk is young people. And for them, about 15% over the 2 years got their condition worsening. If we look at the suicide thoughts and behavior, statistics is actually very disturbing, with almost 1 in 5 young men and adults thinking about the suicide, 1 in 10 planning on suicide, and around 5% attempting on suicide. I'm not going to go into a lot of details about the suicide because I think Jen covered it really, really well. But one thing that I wanted to show is escalation over time. And if you can see, we see that actually among young men, 2.7% over the 2 years escalating from no previous attempt to a first attempt. And if we look at the repeat attempters, people who were asked about their lifetime suicide attempt in 2013, 2014, and if they said that, yes, we've already attempted a suicide, and they've been asked about a suicide attempt in the 2015 and 16, and they said that, yes, we've attempted a suicide within the last 12 months, we see then 0.5% of men repeated a suicide attempt. And it actually equates to 26,000 adult men who repeat the suicide attempt. And again, these statistics are very, very disturbing. The other very big health issue of growing concern is weight status of males. You can see there are two figures, and the first figure on your left shows the increase in the proportion of overweight and obesity among males. And you can see that increase is really, really, really substantial with age. And the most disturbing result is that actually as soon as males become overweight and obese, it's very difficult to break this pattern, at least over a short period of time, like 2 years. Overall, now we're talking about the alcohol. And again, as I mentioned before, a lot of questions were asked about the alcohol consumption and drug abuse. I will focus only briefly on alcohol consumption. And overall, 48% of the respondents in the Tantamount study consume alcohol above recommended guidelines. And again, if we look at the longitudinal data, many adults, males who were engaging in the moderate to high risk alcohol consumption, they tend not to transition to the low risk patterns over time. And this pattern has been very consistent. So if we think about it more broadly, basically the key messages from the very preliminary longitudinal data is that many Australian males who have or develop conditions of ill health tend not to transition out of them, at least over the short period of time. Transitioning to healthier states appear to become increasingly less common as male age. And the other thing that I didn't mention here, but it didn't present the result, but it's a red line across any analysis that we do. And it's not going to surprise to any of you that social determinants play a key role in the male health. And of course, with what we've presented or what I've mentioned today, the whole potential of Tantamount study will be realized with more waves of data collection, because it will allow to demonstrate the causal processes, evaluate the diverse outcomes over time, understand what are the socioeconomic determinants of different health conditions, help us to understand that what is associated with the onset of particular condition, and more importantly, identify a window for best preventive and interventive opportunities. So thank you very much, and I will be stop sharing the screen now. And I think, yes, my video will work now. Yes.
Great. Thank you.
Thank you.
Thank you, Galina. You covered a huge amount of territory in a short amount of time. So as with Jane, if you could keep an eye on the chat box for any questions, and we'll come back to some general questions at the very end. And thank you for also bringing. We have a lot of focus on mental health and suicide prevention in our space, which is really important. But men's health is about some of the most key physical issues, obesity, alcohol abuse and drinking over alcohol guidelines, exercise, all these kinds of things, which you've given us some sort of insight into in that talk as well. So thanks so much. And that by way of neatly linking us to our next speaker as well. So one of the ways we have of engaging with men around physical health is by the use of sport and the sports sector as a way of engaging effectively with men and boys. In fact, we did a whole session in the first, a whole day in the first week of Men's Health Connected, focused on sport and men's health, including a great talk by Professor Phil Morgan, who's done loads of great work, particularly in relation to the role of dads and the impact of their behaviours on their kids' health and well-being. And Professor Morgan recommended that we should reach out to our next speaker. I was aware of a programme in the UK that was focused on using sport to reach out and engage with fans. And I'm glad to say that there are explorations on how we can apply that programme in Australia, particularly in an AFL context. And if you want to know, is Dr. Eleanor Quested. So Eleanor, thanks for being here. Looking forward to finding out about your work. It's great to be working with you for the first time, and I hope it's not the last. Are you there, Eleanor?
Yep, I'm here. Sorry, just the unmute trick. Thank you very much. I'm just going to share my screen as well. Is that working?
Looking good. Just need to, yes, it. Perfect.
Excellent. Okay, well, thanks very much for the opportunity to speak to you today. It's a pleasure to join you over here from Perth. And first of all, I'd just also like to acknowledge the traditional owners of the land I'm presenting to you from today, and also the land where this work was completed, and to acknowledge the Whadjuk people of the Noongar Nation and pay my respects to elders past, present and emerging. So as captured in the introduction there, I'm going to be talking about the Aussie Fit programme, or the Aussie Fans in Training programme, which the broad goal really is to improve the weight status and health and well-being of men in Australia. So as we've already heard today and repeated times really throughout this fantastic forum over the last month, there's really a pressing need to address different disparities in relation to health for men, and obesity is another area that fully deserves full focus, with quite a marked disparity in terms of obesity rates in Australia for men and women. And I won't therefore labour this background, as we've heard some of these points before, but I think what's really key is we know from vast amounts of research that when we can effectively support people to target their diet and physical activity behaviours, we can reduce obesity and many of the health risks that come along with that. But when we actually look at the research, programs that are specifically designed to recruit men or to be tailored for men and to engage men are hugely in the minority, as something like 20% of randomized controlled trials specifically focus on men in terms of weight loss. So there's work to be done. And as we saw in the earlier session in the forum a couple of weeks ago, there's been a growing focus on sport as a type of community-based intervention or sport settings, which have some promise really in addressing some of the gender and social barriers to health that we've been hearing quite a lot about. So this gives us a strong start really in terms of identifying a way that we can possibly try to engage more men in weight loss programs. And one example from the UK, from Scotland and our colleagues over in the University of Glasgow, that's really an excellent example of how this can be done well, is the Football Fans in Training programme. So very briefly, and there's a wealth of publications on this programme, but FIT capitalised on the appeal of sport by using Premier League stadiums and training facilities to hold group-based weight loss programmes. And when tested in a randomised control trial involving over 700 men, the programme was found to be effective in reducing weight, with differences between the intervention and control groups still being found at 12 months, differences of just under 5 kilos in weight. And the FIT programme is also shown to be effective in improving health behaviours and psychological well-being of the men that took part. And I guess really importantly, they've recently published data showing that many of these effects maintained 3.5 years after baseline, which is a really fantastic result and is very rare in any weight loss research that is published internationally. The appeal of the programme as well has really been shown since the trial was established in Scotland and published in 2014. The programme's now ongoing in 42 clubs, Premiership clubs in the UK, and there have been different extensions and pilots in different sports and other countries. So I think the popularity of this programme and others like it really does challenge this outdated notion that was mentioned earlier, that men can't or won't take action for their health. In fact, they very much will. The programme had been successfully adapted for other professional sports settings in different countries. The programme hadn't yet been implemented or evaluated in Australia. And having followed this work closely when I was in the UK, as I was where I come from, as my accent probably gives away, when I moved to Australia 5 years ago, I was really interested in the possibility of trying to establish an Australian version of the Football Fans in Training. So working very closely with colleagues from Glasgow who developed the original FIT programme, this is essentially what we've done. So we obtained funding from Healthway, the West Australian Health Foundation, and got some funding basically to develop the Australian version of FIT, which we cunningly named Aussie Fit, and ran a pilot and feasibility study with 130 men in WA that I'll tell you a little bit about now. So essentially, those of you that follow AFL, or even if you don't, you're probably aware that there's 2 AFL clubs in WA, the West Coast Eagles and the Fremantle Dockers, and both clubs came on board to be part of our pilot activities. And this was really important, really. The partnerships are essential because it's the football clubs and the fandom and the sport and connection and passion for the teams that really help to provide the hook to engage the men in the health behaviour change programme. And I have no doubt that that was far more appealing than any advert that may have come out from Curtin University trying to publicise a health programme. So our protocol paper is also published if you want to read a bit more about the Aussie Fit programme and the trial that we ran. But I'll just tell you a little bit more about it now. So essentially, like the FIT programme, Aussie Fit's delivered in FIT clubs, in football clubs. It's a 12-week programme that runs for 90 minutes per week, and the men come together in groups of 15, led by a coach who's been trained by us. So those 90-minute sessions, broadly over the 12 weeks, work out to be about 50% education and 50% physical activity, but the balance of those adjusts as the programme goes on and their fitness improves. So the education really, as I see it, is the central crux of the programme, because what we're not looking to do is to help people to lose weight for 12 weeks. What we're aiming to help support the men to do is to develop skills and strategies that will enable them to self-regulate their behaviours, both within that 12 weeks and after the programme finishes and throughout their lives. So there were opportunities for physical activity within the sessions, as I'll mention I'll show you some examples of in a second. But really the physical activity focus of the programme was around their physical activity in their daily life. So the men were encouraged to increase their walking, or they could do any activity they wanted. It's important, it's something they enjoyed doing, but walking was popular and turned out to be very appealing activity for the men. And as part of the programme, the men received a Fitbit, which proved to be extremely popular as a way to self-monitor. We also had a social network for the men in each group, so they joined a private Facebook group so they could continue to interact during the 12 weeks. That was entirely run by them and their coach in terms of what they chose to share and discuss on there. And the idea was, as has happened, that the men would stay connected via the group once the 12-week programme finished. So just some examples here, some photo examples of the educational sessions. So they tended to be very practical. The programme was particularly designed to appeal to the type of style of programme that men would be interested in and wanted to engage with. And we were trying to move as far away from a Weight Watchers style of programme as we could. The delivery style was really informal. There was lots of banter, non-stop banter and humour, friendly interaction, and a really strong sense of team and support that the coaches developed. And so, for example, in the top right corner here, you can see the guys in the alcohol session, which was always a popular session where we start to look at what home pause really actually equate to, and essentially to discuss some of the specific barriers and challenges that men may face if they want to try to change the amount of alcohol that they consume. And here's some examples of the physical activities as well that they did during the session. So all activities were, I guess, AFL themed. So for example, the coaches would take the men through the same warm-up routine that they saw their favourite players doing on match day, but obviously modified for their physical activity limitations or their fitness levels. And they do different sort of skill-based drills and so on, which were very, very popular. And another kind of hook, I guess, to the programme was an opportunity for some unique fan experiences. So you'll see the guys here having a tour of the Fremantle Dockers locker room, the room in which I present to you from today. And the other image, some of you may recognise Drew Petrie, who was a recently retired West Coast Eagles player who came and attended one of the sessions and discussed with the men different setbacks he had experienced in his playing career, which were then used as examples for the guys to apply and discuss with him in terms of setbacks they experienced in their behaviour change. So the coaches that delivered the programme were experienced in community or recreational programs. They weren't experts, they weren't nutritionists, they weren't experts in diet. That wasn't necessary, and the type of information was science, but not rocket science, very straightforward and easy to comprehend for the guys. So we ended up with 2 female coaches and 4 male coaches, and they attended training that was delivered by our team. And I guess an important part of the programme was not just the context and the activities and the knowledge, but also the psychological skills and techniques that we infiltrated throughout the programme activities and the style of delivery. So we taught the coaches about those as well during the training, and I'm happy to speak more about that aspect at a later point. So how did the programme go? Well, the programme was advertised in terms of recruitment by the clubs. So we've got some examples here of the posts that they had on their websites. They advertised it via their social media and mail out to fans as well. We had quite an overwhelming response. Within about 3 days at each club, we had 426 men apply for what was in fact only 130 places that we had available on the programme. But in terms of feasibility and appeal, this was quite convincing for us that this is something that men in Australia would be interested in. So I'll just move through a little quicker now because I see time's ticking on. But in terms of who took part, we took baseline measures from the men in terms of their body weight and a range of health indicators. before the programme started, and then we randomised the men. So half of that 130 received the programme immediately and half waited 3 months. So this was the baseline characteristics of all the men who applied to take part in Aussie Fit. And as you can see, we're reaching the group that we're interested in with an average BMI of 35. And the majority of the group, so 83% of the men would classify as overweight. Also noteworthy that 95% of the men that took part in Aussie Fit identified as white. So the results I'll just quickly show you through here now are comparisons of the group that attended the programme with the group that didn't at the 3-month follow-up. So this is a pilot trial essentially where we're trying to see whether this type in preparation hopefully for a larger scale trial. But essentially what we found we're very happy with. The difference between the groups at 3 months in weight was 3.3 kilograms. Men's self-reported overall health, percentage of body weight and BMI also improved in the directions that we'd like. We also saw changes in intake, so for example fat intake and sugar intake reduced, and we used accelerometer devices to measure physical activity. So the men wore a monitor, a sophisticated monitor, to assess how active they were before and after the programme, and we saw significant between group differences in that as well. And then we also saw changes in the in the psychological health of the men that took part, and this was really important, and I guess a key thing that the men reflected on themselves in terms of something that they got from the programme. So improvements in both self-esteem and positive emotions, and also some improvements in some psychological factors that would be important for maintaining their new health behaviours. So for example, development of healthy habits, or having developed life goals that were more consistent and more aligned with their health goals. This is just a flavour really of the intervention group, only at what happened when we followed them up at 6 months. So it's just quite a small group. Men who began the intervention in the first group essentially kept the weight off and continued to lose further weight while they were in that sort of self-management period after the 12-month programme. So that was really encouraging. We're just trawling through a process evaluation and a lot of qualitative data at the moment, but it's just a couple of nice quotes that I wanted to pull out really, that I think really highlight what the programme offered. And as this quote highlights, as this participant John said, that the programme really gave him the skills and the tools, the knowledge and the social support to make the changes of the things that he knew he probably should be doing, and it was a life-changing programme. And then this it really just highlights the way that the habits were integrated through the programme to the point that they didn't even realise they were developing these new habits. Suddenly realise that the programme does what it's supposed to do, and you don't realise till near the end, and then you go, hang on, I've changed what I'm doing, and it's become a habit. So in terms of next steps, we have a couple of new areas of work that are picking up this year. So we're obviously interested in extending the programme to more settings within WA and across Australia, but we're also developing 2 slight adaptations of the programme this year as well. So with funding from the Heart Foundation, we're looking... what's that?
Sorry, just 1 minute to wrap up.
Okay, I'll wrap up. I've been waiting for that warning. So we're looking to develop a variation of the programme for men with cardiovascular disease to try to help to prevent, as a tool for secondary prevention in men with that diagnosis. And in addition, a second issue that we're really looking to tackle is that it's clear that participants in men-only weight management programs tend to be well-educated, metro-based, more advantaged men, and Aussie Fit was no different. So another area of work that we're launching this year is to try to extend the program to reach men from more disadvantaged socioeconomic backgrounds in rural and regional WA, and of course to ensure that we're actually able to address these inequalities, the appropriate adaptation is really essential, and that's going to be the focus of Matt McDonald's PhD, and Matt's in the audience today. there. Thanks for your patience with the presentation. I'd just like to acknowledge the team who were involved in this work, so the project manager, Kwasnika, and the rest of the academic team who were obviously integral to the success of the programme, and also the AFL fans who took part as well, and the coaches that we couldn't have done the programme without. Thank you.
That's fantastic, Eleanor. Thank you. Thanks for speeding up at the end there.
Sorry about that.
No, you're all right. It's all golden stuff.
Get overexcited.
I often talk about how, the positives of men's health in Australia, and including that the amazing programs that Australia has given the world, like Movember and the Men's Sheds movement, and Mates in Construction, and that's just the M's. But it's been heartening from a patriotic perspective to see that we've got programs like Man v Fat and Aussie Fit coming in from the UK. Seems to be sneaking in via the West Coast. But good to see that some of the Scottish in this case, some of the British approaches to men's health are also translatable over to Australia too. So good work. Really interesting conversation going on about different views on use of masculinities, both in one-to-one settings and in preventative approaches. Clearly, we could have a whole day plus on just that one topic. Also, a question in the chat box there about whether there was any link between physical health and mental health that you've been finding. Galina, I can't get that name wrong. Galina, I've got it. Galina, question in the chat box there about any link between physical health and mental health. Any questions for Eleanor? Please pop them in the chat box, and I'm sure she'll be happy to respond. And we've got about just under 20 minutes left, so we've got time for Zach and some questions at the end, as long as Zach doesn't take up the full 20 minutes, which he'd be very capable of doing because he has lots to say. I'll get out of the way, Zach, and hand over to you, Dr. Zac Seidler, to bring us home for this awesome session. Thanks.
I think that is a compliment that I could crap on for more than 20 minutes. Yeah, sure. Okay.
Yeah, it was.
Thank you. Lovely to see everyone again. I feel like this is some kind of dinner party with all my mates over and over again, that I've been doing every week now. But it's great to see that the field is gaining a sense of camaraderie and strength in numbers, which I'm very lucky to be a part of. And I just want to call out, because I don't often get the ability to do so, that I am standing on the shoulder of giants here, and I'm very lucky to have Jane Pirkis in my orbit, as well as John Olive and Simon Rice, without whom I would not be here or doing any of the work that I'm doing. And while Jane, yes, has $5.6 million in her back pocket, I'm going to hopefully be able to take some of that from her and help help out. It's the least I can do. So I'm very lucky to be a part of that grant with Jane, and I'll walk through, I guess, a bit of my work. I have a very keen interest in masculinity and its interaction with mental health and suicide, and I'll just jump on and start sharing my screen. My role at Movember is around mental health training, and I also a research fellow at the University of Melbourne. So I kind of jump between the idea of building interventions and evaluating them. And that's, where all of my focus has been thus far. And I'm very interested in the ideas around strength-based promotion of help seeking and providing services that are actually built with men in mind. And so I always, and I'm sure that many of you have seen my presentations before, start with a picture of myself on holidays, which is not going to be happening for a couple months at least. So this is me and my mates in Dubrovnik, just having a good time. I also always start with this quote, and I think it's really apt given the conversation that Derek and John were having this morning around that cul-de-sac of gender differences research. But as some of the chat was going on the side, and I think Jane would attest to this, presenting it as a contextualizing factor, the fact that there is a very clear discrepancy between men and women when it comes to mental health outcomes is kind of the buy-in that we get and we work on that and then go to a within men approach. So this quote by Angst and Ernst in 1990, "Women seek help, men die," is one of the reasons I'm in this field, because it's just so inescapably morose. And I don't believe that should be the status quo. And hopefully we're going to be starting to challenge that. The reason I do what I do is because of this graph, really. There should not be two trending upwards lines here. We should not be getting more and more men seeking help and yet more and more men dying by suicide. That doesn't make sense to me. That suggests that despite the fact that places like Movember and Headspace and Mates in Construction, everyone is telling men to seek help, it obviously suggests that we're missing the mark in providing help that is going to be useful and appropriate and engaging for these guys. So we need to see one of these lines, preferably the suicide rate, decreasing. And Glenn, I know we had this discussion a few weeks ago where I said, I think this was before we got the 5.6 million, Jane, but I said to Glenn, if we suddenly got $1 billion tomorrow to try and, alleviate male suicide, where would we put it? And it was a very hard question to answer. So I think that says quite a bit about our approach and how much we don't know and how much humility we need here. Something that we do know, though, is that over 60% of men who suicided sought help in the year prior. And that's something that John Olive brought up this morning and says a lot about the mental health system and the fact that stereotype that the men who die by suicide are completely, at odds with the mental health system, are not in contact with them, and they've just completely avoided us. I don't believe to be true. In fact, many of these men are in contact with GPs, psychologists, psychiatrists, and are still slipping through the cracks, which means that we have a lot of work to do. We just completed the largest survey of men's experiences in mental health care the world over. And thanks to Movember's marketing, and Eleanor, I saw your approach going through footy clubs is a very good way of recruiting. Movember's been very good at recruiting through their own marketing as well. And we got 2,000 men in 2 weeks to fill out a 15-minute survey. So we're very lucky there. And they described their experiences to us, because it's enough with making these assumptions about what men want. We need to start to ask them. And we found out that men are talking with their feet. 43% of these guys noted that having been in treatment before, they dropped out prematurely and did not inform their clinician. That really shows that we are very clearly not providing them something that is working for the majority, I guess. Something that I really want to point out here is when we ask them the reasons for them dropping out, that idea that my problems were resolved is something in the literature that everyone goes, oh, that's why they're dropping out. They're not telling you, but they've, everything's good to go. When you actually ask the men, the vast majority of them are saying they didn't connect with the counsellor or it didn't help. Well, the counsellor didn't understand me. And that is really worrying and shows that there is a means for intervention here around upskilling our workforce to be able to address men's needs accordingly. I just want to quickly go through some myth busting, because I think this is fun. According to our survey, the idea that men don't self-refer, that only their wives and mothers, and I've been perpetuating many of these myths, so I'm going to be the first to note that I might be part of the problem, and we're going to start breaking these down one step at a time. But in fact, the most common referral pathway was men themselves. The idea that men feel shame going to therapy. In fact, the vast majority described that they felt none to very little shame. The fact that men aren't motivated to attend therapy. Almost half of them were really, really motivated. Men don't like to talk. Well, the best thing about therapy for the vast majority of them was, having a space to talk. And that men only want to see male clinicians. This is something that's really important. Everyone's really interested in this idea that we need more male clinicians. I believe that we do. I was the only male in my cohort. And that's an issue because we need choice. But female clinicians do just as good a job. And the vast majority, again, of men don't actually have a preference. But, those 20% who want to see men and who want to see women should be able to find a good clinician accordingly. So that really wraps up the idea that we need to stop assuming and start asking. And that means that we need to keep men in mind. And this is where my project comes in, which is to say that the onus should no longer be on men to change to fit therapy. It's about time our mental health system adapts to fit men's needs. You cannot assume that a man walking into treatment has to cry and be emotionally communicative and show his vulnerability immediately and fit in with a stereotypical idea around psychotherapy or counseling that we know is not necessarily the be all and end all and will not work for them. You don't go and see a physiotherapist and the physio says, I can't deal with that knee. That just doesn't happen. They adapt their practice and they provide you with a tailored treatment accordingly. That's what needs to happen. So it's time that the mental health system, really adapts and the practitioners and counselors out there learn what is going to be best practice for working with men rather than trying to shift men's attitudes and beliefs. And so rather than going for the traditional model, which Movember has done a lot of previously, which is going to where men are directly and trying to access them and shift their behavior accordingly. My approach and what I sold to Movember early on, and I guess I sold to Jane as well, successfully, thankfully, is the idea that we need to go to clinicians because we're going to have a huge impact if we've got thousands of guys who are pushing into a treatment room. The access that these clinicians have to changing men's behaviours is huge. And so the Men in Mind program is going to actually address the mental health needs of men by providing these clinicians with the knowledge, skills and attitude change to create these treatment plans and better provide a treatment that is aware of, respectful of, and understanding masculinity and its impact on mental health. So very quickly, we're in the process of putting together the pilot for this program. It's going to be an online, interactive, continuing education course with lots of vignettes, videos, journaling, reflective exercises. And it will walk through the very basics of what masculinity is, I guess, and is assumed to be general knowledge, but we know that many clinicians don't actually know what they're talking about when it comes to this stuff. And then it really looks at your gender, your practice, which is the notion of the interaction between your own gender ideas, your biases, your assumptions, and how that interacts when it comes to treating men. And then Cracking Tough Nuts, which is my favorite title for the third module, which is around engaging and motivating men. And that's where the majority of my research has been, whether it be from language, using metaphors, how to motivate them by speaking to them on their level and asking them how you can ally with them to move forward. And then 4 and 5 are really focused on the work that I've been doing with Simon and John Olive around the fact that distress looks very different in men, the fact that suicidality expresses itself very differently, and the warning signs and risk factors can manifest really differently and need to be picked up on. And we're going to walk through all of this training with 4 key diverse male characters across age groups and ethnicities and sexuality, sexual preferences. So that's kind of where we're at. The clinician survey is done, trying to get a baseline of understanding. Moving forward, we're going to have a pilot program with 150 plus clinicians. And then stage 3 is where I will be knocking on Jane's door, and we're going to be working together to do an RCT of this program. And so the pilot is going to take place around September. So we're very keen to get as many people involved in that as possible. And then the RCT, we've got the APS as a partner, which is really exciting, who are happy to disseminate the program to all of their 25,000 members as well, which is great news. So if you're interested, head to this website and sign up if you're a clinician or a practitioner, and please share with those in the field. And I look forward to updating you in coming months and years around this program, because really, and I think that everyone today is going to agree with this, our vision at Movember, at the AMHF, throughout the Australian men's health space, is that men seek help and men thrive. I think that we need to start to tackle this suicide rate by speaking to men and providing them with what they want and what they need. So thank you very much. That's enough from me.
Great. Oh, yes, I've turned my microphone off. Thank you, Zach. Thank you for bringing us home with 5 minutes to spare. So we are discussing big ideas, and we're sharing research that makes a difference. We've got 5 minutes left, and I'm going to give you each a minute. I'm going to come back to you. You can conclude in any way you like, but I'm going to throw out two provocations or questions, or even just invitations, perhaps. Perhaps they're just invitations. So, in line with the theme, research that makes a difference, what are you personally most proud of in terms of the difference you've made so far? What sort of one little, it can be big or small, but what one little moment of difference making where you've made the connection between research and change in the world are you proudest of? And what difference are you still to make that you most want to make? And because you went last, Zach, you're probably going to get most time to think about that. And Jane, you'll be aware that the pecking order means that I'm coming round to you first. So I'm just extending this sentence a little bit longer to allow you time to think. But the two questions are, what one difference are you proudest of, or makes you glow when you think of a difference that you've made when you saw your research go from paper to actual difference in the world? And what one difference are you still to make that you'd most like to make in this space? Professor Jane Pirkis.
So no question about the thing that I'm most proud of is Man Up, which actually kind of arose from 10 to Men, because we had done some work with 10 to Men which showed that men who were extremely self-reliant were also the most likely to have suicidal thoughts. And so the thing that underpinned Man Up really was demonstrating through a documentary that was widely seen on the ABC that it's absolutely okay to let down your guard and reach out to your mates or for professional help. And we know it made a difference because we did do a randomized control trial before that went to air. So that's what I'm most proud of. And I can't quite remember the wording of your second question, but what I'm still keen to achieve, I think I'd have to say that I'm really keen to do this, fairly big, ambitious program of work that we've been funded to do through Million Minds, because I think that it will really make a difference. I think it will really add to the evidence base about what can potentially work in male suicide prevention.
Right. Thanks, Jane. So we'll definitely be coming back to you a few times over the next 4 years to get some progress reports on that. And I've posted a link to Man Up for anyone who has been living under a rock for the past couple of years and hasn't had a chance to see it yet. So Galina, any thoughts on that? Are you still there? And any thoughts on those two questions?
So the first one, what is the most proud of?
Yeah.
Probably the most proud of is getting 10 to Men up and running for wave 3. Mm-hmm. That was very big and interesting exercise. And to achieve, I think I probably would like to say about the achieve, I really would like 10 to Men to have a completely new life with about 50,000 of males with a huge data linkage, being able to be bigger and sort of, yes, so I think this is the biggest dream of mine, to make 10 to Men much, much bigger, because 16,000 people is not big enough for the longitudinal study moving forward, especially when we've got age range from 10 to 55.
Okay. Right. All right. So we need a bit of a chat with Movember and the footy clubs about getting a few more people in there.
Yes. Thank you.
Excellent. Thanks. And thanks for being here, Galina. I really appreciate it. Eleanor, coming to you.
Interesting question. I think probably what I'd reflect on most in terms of a proud achievement is really at the beginning of the project, when we were actually trying to get the project up and running. We had a lot of challenges for obtaining funding for a project like Aussie Fit that was going to be delivered in settings or with football clubs that had sponsorship from junk food outlets and alcohol sponsorship and so on, given we were applying to a health funder. So our first applications were rejected on these grounds, and we essentially had to make a case that we can't, we need to work from the bottom up, not just from the top down, but punishing the men almost for the financial arrangements of the clubs isn't going to long-term benefit the clubs. And we managed to get Healthway on board with that, and essentially it was interesting to see through the programme the men's attitudes change as well, in terms of what they thought about the sponsorship arrangements that the clubs that they were so passionate about had, and how they started to think differently about some of those things. So that was quite a nice win, I think, at the beginning, that actually enabled the programme to work. And I guess in terms of the second was keen to achieve, wasn't it? And I think the ongoing challenge, I guess, for everybody in the call to some degree, but is trying to identify methods and mechanisms for effective translation and sustainability of the programme. So in terms of the Aussie Fit was available free to the men that took part because of the funding that we had. And we'd like Aussie Fit to always be free to remove barriers to engagement in health behaviour change that become apparent when something requires a charge. But to be able to fund the programme effectively without it necessarily being linked to research, or to be able to be delivered in a range of locations and to reach different men, and to be translatable in different settings where there aren't AFL clubs necessarily available with exactly that hook, will be an exciting challenge for us to pursue over the next couple of years as we look to move the programme to rural and regional areas.
That's brilliant. Thanks, Eleanor. And privately, you're going to have to explain to me at some point how you've travelled from South London to Australia and picked up a bit of a northern accent on the way. But I'll leave that to a private conversation.
Oh dear, sorry.
Whether it's just my ability to listen to accents anymore that I've lost. Dr. Zac Seidler.
What am I most proud of? Well, I would say that my clinical work, while exhausting and draining, is extremely meaningful to me, and being able to see someone who is, who believes that they don't deserve to live necessarily, a young guy, and seeing him, survive, flourish over time is pretty meaningful to me. Nonetheless, the ability to disseminate this stuff and the opportunities that I've been given through Movember and the unis and you, Glenn, as well, to get to talk about this stuff and for it to become commonplace, I guess, in my life and in the lives of the people around me. I'm very privileged for that. And moving forward, God, I'm just stoked about everything, to be honest. This is just like, it's Christmas every day. I love this work, and I'm interested to jump around and do as much as I can. But obviously, with Jane on the call, I have to admit that the upcoming Million Minds project is something that gets me out of bed in the morning, and I'm very excited to see how that's going to make a huge impact. And I'm glad that the government has heeded our call, I guess. And we're gonna make some big strides, no doubt. He's been on Zoom for a month and he still doesn't know how to unmute himself.
He's actually I'm trying to prove that men can multitask and break down gender stereotypes, Dr. Zeidler. I was emailing and talking at the same time there. Nearly got away with it. It really is an exciting time to be in the world of men's health research. And I think, it's a combination of COVID pushing us all online, and also all the different work that's going on has made it the perfect time for us to come and have this first, and what I hope is very much first, Men's Health Research Symposium. Fantastic. Thanks so much, all four of you, for your contribution. Professor Jane Pirkis, Dr. Galina Daragova. Oh, I've done it again. Damn it. I'm sorry, Dr. Galina. Dr. Eleanor Quested and Dr. Zac Seidler. Thanks so much.